Thank you, Matt. It's funny, last week I sort of addressed this group and said it's really important that we all attend these Tuesday lectures and Wednesday lectures, not so much that many of you will say, gee, I'm not going to really deal with any of those issues, but I think it's important here on our team at Aspetar that we do know what other people are doing, that we do have some appreciation for the things that they're going through, what their passions are, what their interests are, and I think you'd be surprised at how much each of these things interact and make us all better, and it's clearly one of the advantages that we have at a place like Aspetar. In other words, we can all just get bogged down and, you know, we got patients to see at 8 o'clock, and we do most of the time, and that's fine, but I think we need to take this time for collegiality and to get together and certainly learn and just have some appreciation for what each of us do. So if I seem like I'm passionate on this topic, I am, the way I got involved in this is in the late 80s and early 90s. I realized that as I practiced medicine in the military, that the military is basically the ultimate crucible of sports medicine, because the guys in their off time they play sports, in their on time they train in physically active things where they run and twist and jump and do the same kind of things. So really they have double opportunity to injure themselves, ACLs, etc. And I realized early on that our treatments for articular cartilage injuries were very ineffective, and that although there may be temporary results, there was nothing lasting. And you'd see case after case of a 26 or 27-year-old with a worn out knee, completely worn out, without other options. You really look for other things. So it's sort of knowing what was going on in the world stage in 1994, when the first article came out about autologous chondrocyte implantation from Sweden, from Lars Peterson, Mats Brittberg. I was well aware of what was going on, and I had the opportunity to go to Sweden in 1995 and really begin the trying to bring the next level of treatment to articular cartilage. So what we'd really like to do is get from the left up there, which is an acute injury. There's a treatment in between with chondrocyte implantation, and there's the follow-up at 2 years that show healthy return of the articular cartilage. And I wish we could guarantee that all the time, but it certainly is better than most in many cases. So treatment of articular cartilage defects, it's really patient-specific. You can't say one size fits all. You can't say we're going to do the same thing on each of these next 10 patients. You can't. You have to look at all the different characteristics, as we'll see, and I'll go through those things. Cartilage surgery is not just one thing. Some things are simple, some things are complex, and the complex things generally require more time for the patient to recover. And then, like anything, evidence-based decision making, don't just do what's easy, and also you can't just look at the chondral defect in isolation. You have to look at the whole knee and the whole person. So what are the factors that influence cartilage repair? Well, obviously the defect itself, the size of it, makes a big difference. The location or locations, more than one lesion can happen. But if you look at the difference between a small lesion and a large lesion over there, just look at the difference of the edge wear over there of these forces, depending on the size of the lesion. That's why things are different. Then you have to look at patient characteristics, how long the symptoms have been present, prior injury, prior surgeries, BMI, age, activity level, etc. So articular cartilage is a wonderful thing, and it's basically made up of about 5% is chondrocytes, and 95% are the matrix. That's the white stuff that you see. It's actually matrix, and that's really what we need to recreate. That's the thing that has the biomechanical properties. Well, articular cartilage minimizes friction. It's 1/7 the friction of ice on ice. So that means it's 7 times slipperier than ice on ice, so it's pretty good. Load distribution, it really makes a big difference in protecting the subchondral bone. It enhances the range of motion, and without injury, articular cartilage has a half-life of 114 years. So it doesn't mean you wear out. You can run a marathon when you're 80 if everything else fits and if everything else is okay. So it doesn't just wear out with age, it only wears out with injury or malformation or malalignment that allows excessive load. Our goals, very briefly, restore the surface, relieve patient symptoms, improve function. That's the one thing that we probably do of this whole list. The rest of them we do partially. Match the biomechanical properties of normal hyaline cartilage. Nope, we're not there yet. We do a pretty good job, but not as often as we'd like. And then prevent or slow the progression of chondral injury to arthritis, just like we know in ACLs. You know, maybe we can say we do some, but we certainly don't do it completely. So really the answer to cartilage is on this slide, if somebody can just figure it out. It's some combination of these factors, the signaling factors, the small molecule proteins, TGF-beta, hepatocyte growth factor, different things, a matrix or a scaffold that allows for cell formation to occur. And are the cells, do we need chondrocytes? Do we need stem cells? Do we need adipocytes? What's going to be the best combination? And certainly we don't know, but somewhere there's a formula that someday we'll get to, and hopefully it'll be sooner rather than later. So the problem with articular cartilage is it's a pretty common thing. So, but articular cartilage by itself doesn't repair itself. Noted in the time of Hippocrates in 2000 BC, once it's injured, it does not repair. And so it's avascular, has no blood vessels, aneural, has no nerve supply. And the injury is occurring in a large percentage of patients. In a study by Walt Curl of over 31,000 knee scopes, about 5.3% patients less than 40 had full thickness chondral defects. And then the elusive long-term alteration of the natural history. What can we do to change the natural history? We're still working on that problem. This is a study that I did in NFL players in 2010 and found that in asymptomatic patients, and anybody who works in screening will understand that I put in parentheses self-reported that they were asymptomatic. In other words, they said they didn't hurt. But we found routinely 12% in the patellofemoral joint, and then 8 and 10% in the medial and lateral compartments had full thickness chondral defects. By position, linebackers had 32%. That's the guy that plays on defense right behind the middle line and goes both directions and tries to get his nose in there and tackle people or cover passes, and certainly the most active position. 32% had full thickness chondral defects, but still were presenting to play at the highest level of sport in America, in the NFL, and were asymptomatic. So if you, the other thing that we found is associated injuries, meniscal injury and ACL injuries were also predictive of having also a chondral injury. But most significantly, radiographic changes, you can see the joint space narrowing there on the lateral side, were predictive of chondral injury. As a matter of fact, if you had bony changes on x-ray, it's why, Ahmad, we need to get the 45-degree view, 93% had a full thickness chondral defect once they had changes on x-ray. So if you have changes on x-ray, you can pretty much think that, that part of the joint is going to have a full thickness chondral defect. Now, if we look at that dichotomy of those players with defects who are playing at the highest level, it means we don't quite know everything. It's not like it's an automatic. Look at this study in 2010, found that patients with focal cartilage lesions who complained of them, those who were symptomatic, they rated worse than patients who had ACL deficiency, and even worse than patients who had total knees, who were coming up to get a total knee, based on the KOOS quality of life subscale. And so I think, so in those patients, they're really bad off, and how do we compare those to the ones I just said who are still playing? Shows how little we understand about the natural history. From a non-operative standpoint, there's multiple techniques that certainly in sports medicine clinic you have to deal with this all the time. Hopefully orthobiologics might provide us some way to be able to provide some effective treatment without too much intervention. We'll certainly see how that bears out. From a surgical standpoint, arthroscopic debridement, chondroplasty, edge stabilization, marrow stimulation, osteochondral transfers, either with the patient's own tissue, autografts, or with a cadaver tissue, allograft, particulated juvenile cartilage, that's cartilage taken from less than 13-year-olds that have died and their specimens have been donated, and then also autologous chondrocyte implantation, either with a membrane or a matrix, different generations. So what this slide really shows, if we look at mesenchymal stem cells, which is what marrow stimulation or microfracture is, two of the three things that can happen are not ideal. Mesenchymal stem cells can turn into fibrous tissue, they can turn into hypertrophic cartilage, or they can turn into hyaline-like cartilage. Well, two of these aren't good for long term, but to turn into hyaline cartilage, which is a tissue, that's what we really want, and that's why autologous chondrocytes in the lower left, those are precursor cells of chondrocytes. They can only grow up to be cartilage. They can't grow up to be fibrous tissue or other things. And so that's ideally, we think that the cell type makes a difference. So many of you maybe haven't seen some of these procedures. You hear the terms, so I'm just going to review them very briefly. Microfracture or marrow stimulation, basically take an ice pick and stick it in the lesion, and by making a little propagated fracture hole, the little lines of the fracture give more surface area for the clot to form, and the clot's there in the lower right of the slide, and that's really what you're trying to do. You're trying to bring marrow cells out which have stem cells in it to be able to affect a repair. Here's an autograft transfer. Remember, autograft is from yourself. So you rob from Peter to pay Paul. You take a small dowel of cartilage and bone from one area of the knee that you don't need quite so much and put it into the defect, as you see in the lower right. Osteochondral allograft, a little bit more invasive. Here a specimen is used in the lower left, and a dowel is drilled that then replaces the cartilage and bone into the knee, and this is a fairly severe case. ACI, I couldn't resist the option to kind of show this in a little bit more detail. It's got disadvantages, however. It's a two-stage procedure, requires a biopsy and then a separate implantation, and certainly the cost of the cells is a concern, and the cost of a lot of these new technologies are certainly a concern. But there's the defect in the upper left, there's the biopsy, a couple small slivers about the size of 2 pencil erasers is how much tissue you need, and that's in the biopsy medium. That's then sent and cultured, and about 3 to 4 weeks later, or 3 to 4 months later, whenever you want, you come back and debride the defect, which is basically stabilize the edges, as you see in the lower right, that it's now, the edges are clear, demarcated to healthy tissue. Then we cut a little patch of, it used to be periosteum, and now it's something called an absorbable collagen membrane with type 1 and type 3 collagen. It's seeded with the cells, as you can see on the right. And then this use of the absorbable collagen membrane has cut the side effects of ACI from a reoperation rate of 25 to 50% down to really less than 5%, because the periosteum kept growing inside the knee and would be thickened and you'd have to go back just to thin that out. That's not the case anymore. This collagen membrane is then sewn in place with multiple 6-0 vicryl sutures, absorbable sutures, gives a watertight seal. It's sealed with fibrin glue, and then the cells are injected below the patch and then sealed the injection hole, and the cells set up on the bone within 4 to 6 hours and establish and start growing. So patient evaluation with cartilage lesions, like any patient, physical exam is very important. We want to get all the information we can from past studies, but certainly do a thorough exam and look at the complete picture of the knee, and alignment is a critical thing to look at. And that's what we want to make sure that we get all the information we can. And here's the importance of the standing 45-degree views. If you look in the lower left, you'd be hard-pressed to say those knees are any different than each other. And in fact, you probably can't even see any changes. And yet, when you bend it 45 degrees, see the joint space narrowing here compared to that one? That's the lateral compartment. What did we say before? What's the chances that that's going to have a chondral defect? 93%. So pretty significant to be able to get that from an x-ray, not even have an MRI. And you know that's going to be a problem. Sure enough, the long limb alignment film shows that they're in valgus malalignment, and they'll need an osteotomy before they need anything else. So other treatment decision-making things, size makes a difference. Small lesions are different than large lesions, as we said, and all chondral defects are not osteoarthritis. The definition of osteoarthritis varies by study and author, but the one thing that we all don't deny is if there's kissing lesions, two opposing surfaces, the femur and the tibia, as you see in the lower right. Obviously there's degenerative meniscal tear. That's arthritis, when there's kissing lesions like that, where the both surfaces are worn out. So, size of the defect. Small lesions are considered less than 2 centimeters squared. Large lesions are 4 centimeters squared. So small lesions have more treatment options, can be treated with marrow stimulation, Oates autografts, and edge stabilization effectively and return to sport, as we'll see, whereas large lesions, that same treatment method doesn't really work. And numerous studies have shown that as you get over 4 square centimeters, you need to get to these more advanced techniques, which are ACI, chondrocyte implantation, or Oates allografts. And if you try to do microfracture or something else, the patient's going to fail and have a bad outcome, as we'll see. So the apparent cutoff is somewhere between 2 and 4 square centimeters. Some studies have shown that microfracture, anything over 4, results were disastrous within 18 months, and others have shown that it makes a difference just at 2 square centimeters. So consequently, that's the variability. 2 to 4 is sort of a no man's land. Over 4 is a large lesion. Under 2 is a small lesion. We know we can do small lesions with other techniques, but large lesions are better suited with ACI or allograft. Now, the problem with doing microfracture in large lesions is about 30% of microfractured lesions develop these things called intralesional osteophytes. And you can see in the lower right where I have the arrow, it's basically like an island popping up in the ocean, like a volcanic island. Shouldn't be there. The ocean should be flat on top, and so now you have a stress riser right in the middle of the joint of extra bone, so obviously that's not a good thing and predicts a poor outcome. Patients that have large chondral defects typically have concomitant pathology, meaning malalignment, ligamentous instability, meniscal pathology, and for these type procedures, rehabilitation is usually slower due to the increased volume of tissue to mature and or incorporate. So if we look at cartilage repair procedures, as the complexity increases, the options at the top, the amount of time to rehabilitate and return to play goes way up. So almost 12 to 18 months for effective return from an ACI, 9 to 12 months for osteochondral allografts, whereas chondroplasty and microfracture and Oates autografts are more in the 4 to 6 month range, and that's why it's selected sometimes for and is valid for small lesions. But if you take an extra 6 months, and it's the difference between whether you play your career for an additional 8 years versus 1 year or 2 years, the time really doesn't make that much difference. This is just something that in my first 100 or so patients that I think is so important to note about cellular repair. So between pre-op and year 1, we had great improvement by this modified Cincinnati scale with a statistically significant difference. But the key thing is between year 1 and year 2, we had continued improvement. Slow maturation of those cells, the long-term maturation, responding to the load that it sees, continuing to improve up to 2 years, whereas other techniques like marrow stimulation, they fall off by 12 to 18 months and get worse from thereafter. So I think that's the allure of cellular repair. So if we look at these large lesions, not only for high demand patients, which are most athletes, we consider these more advanced techniques, and certainly as a secondary treatment when someone has failed another treatment, the same thing is true. And here's just some specialized cases, mediofemoral condyle OCD in adults, fixed by both ACI and allograft. Here's a massive lesion, multiple lesions. There really isn't another technique to effectively fix these other than ACI. Here's a case of a former NBA player, now at 42, his career is over, tries to run basketball clinics and basketball camps, effectively unable to do much of anything. So he has ACI of all these lesions, total of 29 square centimeters were his realignments, but there at 8 months, you can see the secondary effects of each of these, with each of the lesions fully filled in. The trochlea, a special thing below the patella, a very difficult area to treat, but because the patch can curve around the contours, we can recreate the topography of the surfaces in the knee to include the patella and the trochlea. So what about bone loss? So osteochondral lesions, a more significant problem. Here's a technique for a staged bone graft. So we put bone in first. It can all be done arthroscopic. The bone is stolen from the femur up top, backfilled with allograft bone, then minced up and put in through the arthroscope, packed in place, sealed with fibrin glue, and then you come back 6 months later and be able to put cells on top. And you note this patient also required an osteotomy for malalignment. All right, location of the defects. Femoral condyles do the best, and for large lesions, again, ACI and Oates allografts do the best. And as you get bigger, they do less well with marrow stimulation. And we found that lesions that were bigger than 4 square centimeters did just as well as smaller lesions. So you'd think, oh gee, the bigger it is, the harder it's going to be. That's really not true, provided you correct the concomitant pathology, meniscal deficiency, ligamentous instability, malalignment. If you correct those, then you can get outstanding results. Now, it's been known, certainly in orthopedic circles, that the patellofemoral joint is special. The results are not as good with that, and it's really been tainted by some literature, as I'll show you here in a second. But in each of the techniques, microfracture, here's Oates autograft, osteochondral allografts, the results were not as good as the femoral condyles. In some cases, the Oates autograft, George Bentley from Great Britain, 100% failure in the patella. And the thing that's been really tainted is the original study by Matt Spritberg and Lars Peterson showed at ACI they had poor results in the patellofemoral joint, only 28% good and excellent results. Well, that really represents 7 patients, and 5 didn't do well, 2 did. And the entire labeling of the patellofemoral joint for ACI has been tainted by those 7 patients, the most important patients in cartilage repair. I'm going to show you why it's such a fallacy here in a minute. So we'll get to that. But in the patellofemoral joint, if you realign the joint, anteromedialization of the tibial tubercle, that takes the load off, it corrects the maltracking, the results actually go up to over 80% good and excellent result, and that just wasn't appreciated early on. So from those initial 7 patients, we now have multiple studies that have, in my study, over 11-year follow-up, with over 80% good and excellent if you realign the patella at the same time. So a tibial tubercle osteotomy, that's the 2 screws that you see there that have both elevated and medialized the tibial tubercle. So this is a good case of knowing what the literature says. So here in this study is about 20 years worth of data. The data in the red is patellofemoral joint ACI without realignment. There's those 28%, those 7 patients in the top that tainted the entire thing. Whereas if you realigned it, look at the green. So for 20 years, good. Here's one of my studies in 2014, another multi-center study, 83 and 86%. We had up to 11-year follow-up to show that. So again, if you look at the evidence, as long as you realign the patellofemoral joint, it does pretty outstanding on both the patella and the trochlea. And here's just an example. So bad-looking case. Any orthopedist would tell you that's really tough. Got kissing lesions in the patella and the trochlea, but there they are, both treated with ACI, and there's the outcome at 2 years second look. What about prior treatments as a predictor? Well, studies show that because of those intralesional osteophytes, remember the little Hawaiian islands that grow up in the ocean, that if those fail and you come back and try to do ACI on top of it, it's 3 times the failure rate of ACI. It goes from 8% don't do well to 24% that do well. And in one of the most elegant studies ever, they found that in 15 of the patients that they studied, that they actually had a control within the same knee. So you do ACI on both those lesions. That's a virgin lesion on the left. That's a previous microfractured one on the right. And you can just see it looks bad. I mean, the bone looks very affected. And the one on the left would do very well, and the one on the right has a 3 times higher failure rate. What about prior treatments and reoperation? Study Youngman in 2012 showed that previous marrow stimulation, previous surgeries, female gender, and previous periosteal patch-covered membrane increased the chances of reoperation. Fortunately, we don't use periosteum anymore, and that's cut down a lot on the effect. They did not find an effect from most other things, as other authors have. What about duration of symptoms? If it's less than 2 years, DeWent found in high-level athletes that they had a better treatment for any kind of cartilage repair. Other studies have found, for example, in professional soccer and adolescents with less than 12 months of symptoms, they had a better outcome than those that had that had more than 12 months of activity. And so, age, how does age influence things? Well, again, you'd think older age, tougher it is to fix, but not true for ACI or Oates allograft because we are putting in cells. But the reason that that's true for other techniques like microfracture is in an 18-year-old, if you put holes to get marrow stimulation, there's 1 stem cell per 200,000 marrow cells. So that's good, but if you're 60, there's only 1 stem cell in 2 million marrow cells. So you have much less stem cells as you get older. So systems that rely on stem cells don't do as well as you can imagine. BMI, this pretty much fits with common sense. These are studies that show both for ACI and microfracture as you got over 25 in BMI, and certainly over 30 or 35, results are affected as you'd expect. Simple versus complex. Complex knees involve all those other things that we talked about, larger lesions. Well, in fact, for ACI, it's not true. Simple does just as well as complex, provided you treat all the other problems. And so the other problems are, it's not only the cartilage defect, it's instability from an ACL tear, malalignment, either the tibiofemoral joint or the patellofemoral joint, or meniscal deficiency, and those problems need to be concomitantly corrected. So for each of these things, ligamentous reconstruction, obviously, a tibiofemoral osteotomy, patellofemoral realignment, or a meniscal transplant or osteotomy for meniscal deficiency. If we look at predictors for return to play, ideally cartilage lesions that are in younger athletes with a higher skill level with duration of symptoms less than a year do better than the opposite. And that sort of makes sense because the longer you have a problem inside the knee, the more the overall cytokines and different catabolic enzymes affect the rest of the knee. So it's harder to recover the longer that you've had symptoms. And again, smaller lesions did better than larger lesions, or then came back quicker than larger lesions. If we look at short-term results, high probability for return to play with Oates autograft as opposed to microfracture. Microfracture had the poorest return in the National Football League in the U.S., whereas others have shown that sports participation in microfractured athletes deteriorates after 8 months and actually had worse outcomes the larger the lesion was. Long-term effects, 87% of professional soccer players remained at their previous sports level at 52 months follow-up, so it's a little over 4 years that this study was done. No influence of size of the lesion, and higher scores, outcome scores for ACI than microfracture in professional athletes and adolescent athletes with larger defects. So again, just a couple of cases. Here's an osteotomy. This is much like Cristiano had the osteotomy right here, but fortunately he did not have the large defect of the medial femoral condyle, but there's the result at a year. Here's an allograft technique using a cadaveric specimen, but you can just see by how far off that alignment is on the left that if you don't correct that, you've got no chance. It's a great example. If you tell a patient, if your car's pulling to the left and your tires wear down in the front, if you go replace those tires with brand new Michelin, the best racing tires there are, what's going to happen? Every patient universally says they're going to wear out again. But if you correct your steering, doesn't matter. It's going to be okay. And they get it about correcting the steering. This is the case. You got to correct the steering and then replace the tire. You can't do one without the other. And so that's what this case and any case with an osteotomy represents. And then here's a more extreme for the patellofemoral joint. This is totally worn out in young patients, where actually you take a cadaver piece of the whole patella, and it's almost like doing a total joint with a cadaver specimen. Actually use headless screws to countersink it and put things together and replace the entire the patella with an allograft for a salvage type technique. And then another example of a lateral meniscal transplant done at the same time with the large lesion that you see in the lateral femoral condyle. And there's the second look at a year. And this was in a tennis player, a college tennis player, that had had 3 prior lateral meniscectomies. So anytime someone's had multiple surgeries on the same meniscus, you can be sure that that meniscus is non-functioning and requires additional treatment. So then one final, so you don't just think it's me that says this, this is the editorial comment from Jim Lubowitz, who is the editor-in-chief of Arthroscopy Journal in 2015, says ACI shows greater durability, lower failure rates, and is effective for larger lesions compared with microfracture. In addition, membrane ACI is technically simpler, fewer complications of cartilage hypertrophy, etc. Having just come from the American Academy of Orthopedic Surgeons meeting in Chicago, update in cartilage treatment, the greater trend is to realize that traditional microfracture just isn't in our best interest for our athletes. It's the place where in these smaller lesions, I think to do some of the scaffolds and other techniques that the Department of Surgery has been doing here makes more sense for smaller lesions, but it still shouldn't be done in larger lesions. There's newer techniques for doing microfracture, little drill holes instead of trying to just puncture it with an ice pick that I think make more sense, and we certainly just need to keep track of the results. I think it also shows the one thing we've seen here is we don't know the natural history of these cartilage lesions. All these things look horrible, but these are the symptomatic patients that come in. What about those 20% of NFL players? What's the natural history of them who are going to go through and play and are asymptomatic? Are they guaranteed that at 10 years they're going to be arthritic? Or we don't know that process yet. And we're actually trying to put together a study here with Mats Brittberg and others, Department of Rehab and Radiology and Research, to try to trace the natural history of chondral defects in asymptomatic football players here in Qatar, and that's something that hopefully we'll be able to do over the next 2 years. So in summary, understand what the literature demonstrates. Don't put square pegs in round holes. It only makes it worse. You're not really helping anything. Large lesions are better treated with ACI or Oates allograft, not microfracture. Just doing microfracture because it's easy is not the right thing. It actually creates more problems down the road. Smaller lesions, marrow stimulations for short-term results, or as I mentioned, here's the best place to try that new technology with the additive scaffolds, the biocargel and different things like that, and finally treat the whole knee, not just the chondral defect. Thank you.